We shall now go on to our next speaker, Sheetal, who I've already introduced, and on to you, Sheetal.
Thank you so much, ma'am. I think the slides are now visible.
Yeah.
Okay, thank you so much, and good evening, everyone. Today I'll be talking about how to handle regression after corneal refractive surgery. So, by definition, what is refractive regression? So, it's a gradual, partial, or complete loss of the attempted correction and is defined as residual myopia or hyperopia of 0.2 diopters or greater shift occurring between two follow-up visits 8 weeks apart. It's very important to understand that the mechanisms of refractive regression, they arise from the changes at the level of the cornea. So these are the changes that occur in the cornea during the healing phase after a corneal refractive surgery, LASIK, PRK or SMILE, as opposed to any kind of refractive change occurring in the lens or in the axial length of the eye. So we all know there are some risk factors and causes which we are aware of: high preoperative refractive errors, young age, hyperopic refractive error, postoperative epithelial hyperplasia and stromal remodeling, abrupt discontinuation of steroids, especially after PRK, and postoperative dry eye is also linked with regression after corneal refractive surgeries. It's very important to differentiate a true regression from other causes of postoperative residual refractive error, such as improper data entry, decentered ablation, fluence issues, over or underdone nomogram, and intraoperative dehydration of the cornea. So while evaluating these cases, it's again important to understand the normal healing processes that occur after laser surgery, such as you might see a little bit of overcorrection in refractive error in the first few weeks after the surgery, and that's basically due to the calculated nomograms, the laser nomograms that we use that aim at slight overcorrection and they anticipate a natural regression of the effect. There could also be a little bit of induced astigmatism due to stromal and epithelial remodeling due to tear film disruption. So we must be aware of all these things. So a very important question is when to treat for regression. So I would say a very minimum amount of refractive error such as 0.5, 0.75 sometime may not need a treatment if the patient is comfortable and is not complaining. However, if the residual refractive error is significant enough or the postoperative abrasion profile is affecting the quality of vision and the daily activities of the patient, I think you must decide about treating it. And the decision making differs from surgeon to surgeon and with the availability or experience that they have with a particular enhancement method. So the general guiding principles are you must wait for at least a period of 3 months and allow the refraction to stabilize. Ideal, I would say, is about 6 months, but sometimes the patients are very unhappy and they keep coming to you. So at least you should wait for 3 to 4 months if you want to plan enhancement. Correct elucidation of cause of error. So as I said earlier, differentiated from the other causes of residual refractive error. Proper counseling, and there should not be any contraindication for the chosen method of enhancement. So to evaluate, we must evaluate the vision of the patient, uncorrected and best corrected, manifest refraction, cycloplegic refraction is required to rule out accommodative spasm, and topography is really important to rule out postoperative LASIK ectasia as it could mimic early regression in early stages of ectasia, and also ASOCT to measure the flap thickness or the cap thickness and the residual bed thickness as well, which is very important to plan the enhancement. So early regression versus early ectasia. Here we have two maps. The first one is of a patient who had -9 power and he had LASIK, and after 6 months accepted a power of -1 with 0.75. And on the other hand, there is a moderate myopic patient who after 3 years of LASIK accepts the similar amount of power. So if we see the maps, the epithelial maps, the first map shows significant amount of thickening of the epithelium in the center, which is very classical of the early regression. And on the other side, we have thinning of the epithelium in the center, and this is surrounded by a donut-shaped thick epithelium, which is the pathognomic of early ectasia. So this is how topography and especially epithelial maps can help. So a medical management of regression has been described, and they say there is a forward shift theory wherein they say that the cornea becomes thin. Because the cornea becomes thin after refractive surgery, it becomes weak, and combined with high IOP, it can result in elevation of the anterior as well as the posterior surfaces, and this can contribute to myopic regression. And hence, if you lower the IOP, this may reduce the shift. So this is the basically funda behind it. So people have tried mipradilol 2.5% twice daily and timolol also, and they have seen good results. However, we don't really have personal experience with this type of management. So talking about different procedures, PRK versus LASIK versus SMILE, I think treating regression after PRK is probably most difficult because we have less options available. Repeat PRK is a possibility. However, we must be very cautious because there may be much higher risk of having corneal haze post-operatively. So might want to use mitomycin intraoperatively for a longer period of time, maybe about 1 minute, and also put the patient on a longer course of steroids. There is also option of thin flap LASIK or LASIK extra enhancement that has been described. To manage regression post-LASIK, there are various options: flap relift, flap recutting and making a new flap, side cut only, and surface treatment. So depending upon residual bed thickness and the quality of flap edge, you can have different options. So if the RST is good and the quality of flap edge is also good, so which means that the flap edge should not have already epithelial ingrowth, or there should not be any melting or irregularity, then you can easily go ahead and relift the flap. But it has to be done in the most atraumatic manner so that you don't disturb the epithelium too much, because epithelial ingrowth incidence increases by 20 to 31% post relift. On the other hand, if the residual bed thickness is adequate but the quality of the flap edge is poor, then you have two options. The first option is flap recut at a deeper depth. So you want to make a deeper flap which is at least 15 to 20 microns deeper and also wider, and then you lift the previous flap along with the new flap. So this is a possibility if RST is good, or you can also make only a side cut which is in the original flap but a little smaller, about 1 millimeter smaller than the previous flap. So this is a video showing only side cut management for enhancement. So this flap is actually smaller compared to the original flap. So this can be used if the quality of the previous flap edge is not good. In a scenario where the RST is inadequate but the quality of flap edge is good, you can have two options again. If the flap is thick, 140 microns or more, then you can go ahead and do a flap recut. That is, you can make a thinner flap, or you can do also SMILE with a thin cap. Or you also have the option of doing a thin flap or a surface ablation in this scenario. If you have RST which is inadequate and also the quality of the flap edge is poor, then you don't have any option but to go ahead only with the surface ablation. So what are the options for enhancement in SMILE? We have surface ablation, thin flap LASIK, circle software, and subcap lenticule extraction, which is called ReSMILE or SMILE on SMILE. So PRK after SMILE is probably the simplest procedure that can be done. It is ideal for low enhancements. The mitomycin C might have to be used for longer time, again to prevent haze. It maintains the advantage of a flapless procedure. Thin flap LASIK has been described by Professor Dan Weinstein, and this is ideal for those cases of SMILE where the cap thickness was thicker, 135 microns or more, and you have to make a very thin flap of 80 to 90 microns, and you have to be careful that the hinge has to be away from the previous SMILE access incision. Circle software is a dedicated software for enhancement after SMILE, and this allows the surgeon to convert SMILE cap into a flap, and it provides three types of cuts: lamellar ring, this is the lamellar ring, a side cut with a hinge, and a junctional cut which joins the previous interface. So depending upon the relationship of these three cuts, there are different patterns of circle treatment available: pattern A, B, C, and D. D is probably the most commonly used and also has been shown with shown to have easy flap lifts, and there are not many difficulties faced with this type of pattern. So this is a circle software being used for enhancement, the lamellar ring creation as well as the side cut. So smile on smile has also been described, and this is a possibility when you already know the previous smile parameters. So you need to know the previous cap thickness and the optical zone, because you will be planning the treatment at the same cap thickness, but you will be reducing the optical zone so that the side cut is so that it joins the previous interface. And this again is advantageous for maintaining a flapless procedure. This is a short video showing smile on smile procedure for enhancement. So you need to plan the lenticule cut and the side cut only. And when it comes to the cap cut is about to start, you need to lift the foot pedal and break the suction manually. And then you can go ahead and separate both the interfaces and remove the lenticule through the old or the previous smile incision. So you've done one case, two cases of smile on smile, and this method can be used for residual refractive errors which are higher, but this is suitable only if you have access to the pre-smile parameters, the previous parameters. Thank you so much for your kind attention.
Thank you very much, Sheetal. That was an amazing talk, and I had a lot of questions, but I think I have to do justice to some very good speakers who are yet to talk. I think, yes, I don't know whether you already added, but we definitely need to do a biometry in most of these cases where to rule out that whether we are dealing with regression or an increase in axial length.